Okay, so our presentation is on liver cirrhosis. We're going to be going through etiology, risk factors, what a patient with cirrhosis might look like in the clinical setting, labs and diagnostics to help confirm liver cirrhosis, therapeutic treatments, patient education, and then we're also going to go a bit more in depth regarding the pathophysiology. So, to start, cirrhosis is a progressive, irreversible liver disease that results from long term cellular injury, which leads to fibrosis, regenerative nodules, and disruption of normal liver structure. The body relies on the liver for a lot of vital functions like blood filtering, metabolism, as well as detoxification. There are many different causes for cirrhosis, but the most common causes are going to be chronic alcohol use, viral hepatitis, most commonly B and C, and metabolic associated steatotic liver disease, which itself is associated with obesity, diabetes, and metabolic syndrome. Whatever the cause, cirrhosis pretty much follows a common pathway. So we're going to see persistent liver injury and followed by inflammation and activation of hepatic stellate cells, which produce excess collagen and set the ground for tissue scarring and later liver dysfunction. So for risk factors, kind of touched on most of them, but again, chronic hepatitis B or C, excessive alcohol consumption, obesity and metabolic syndromes, type 2 diabetes, being of male sex, advancing age, dyslipidemia, and other metabolic disorders. Again, this disease is a progressive disease, so it happens over time, and these factors can contribute to ongoing liver inflammation and injury, which can eventually lead to fibrosis and cirrhosis.
Okay, so signs and symptoms. In early cirrhosis, patients may be asymptomatic or have mild, nonspecific symptoms. These include fatigue, nausea, and loss of appetite, abdominal discomfort, and mild cognitive changes like sleep disturbances or mood changes. Progressive symptoms or late symptoms you'd see in more advanced disease are jaundice, ascites, peripheral edema, pruritus, weight loss, easy bleeding and bruising, reproductive changes in men and women, such as amenorrhea in women and testicular atrophy in men, spider angiomas, liver changes. In early cirrhosis, the liver is enlarged and firm, then it shrinks and becomes hard and nodular in advanced disease. Splenomegaly is common in non-alcoholic causes, and osterixis, which is a hand flapping tremor, also a sign of hepatic encephalopathy. Serious complications include hepatic encephalopathy, portal hypertension, variceal bleeding, and spontaneous bacterial peritonitis. For lab and diagnostics, in lab findings, you'd see elevated liver enzymes, elevated AST and ALT, bilirubin, ammonia levels, and impaired clotting, so prolonged PT and elevated INR. For imaging studies, there's an ultrasound, which is often the first line imaging test. It detects ascites, liver changes, splenomegaly, and biliary duct obstruction. There's the Doppler ultrasound, which assesses portal blood flow and portal vein thrombosis, and transient elastography, which measures liver stiffness or fibrosis severity of liver tissue. There's also you can also do a liver biopsy, which confirms diagnosis and determines disease severity, but there is a high bleeding risk. So the transjugular liver biopsy is a safer alternative via the jugular vein to reduce bleeding risk. Other procedures include endoscopic variceal ligation, sclerotherapy for bleeding varices, screening and endoscopy for early detection of varices, and paracentesis, commonly used clinically for ascites.
Okay, and then for the non-pharmacological and supportive therapies, you're going to want to have the patient avoid any use of alcohol, smoking, and illicit drugs, as they're hepatic toxic and they can increase metabolic demand. You're going to want to have them follow a low sodium diet to reduce atelectasis and fluid retention. And that diet should consist of high carbohydrates, moderate fat, and protein to support healing. In the patients, you're going to want to supplement vitamins. You're going to want to supplement vitamins, especially fat soluble vitamins, so A, D, E, K, and B, due to malabsorption and liver dysfunction. And with ascites, it's common to have pressure on the diaphragm. So elevating the head of the bed for the patient will improve their breathing. You want to make sure they have easy access to the bathroom because they're going to be on diuretics and lactulose is a laxative. For the for the medications, you're going to want to do a non-selective beta blocker, propranolol, to reduce portal hypertension and risk of varicose bleeding. Diuretics, so a combination of furosemide and spironolactone to treat atelectasis and reduce fluid retention and maintain potassium balance. Lactulose is going to be your first-line treatment for hepatic encephalopathy, and it's going to reduce the ammonia. It's going to reduce ammonia and absorption and promote excretion of the ammonia. And then rifaximin is going to reduce intestinal bacteria that produce ammonia, and it's going to be used if lactulose isn't tolerated by the patient.
Okay, so patient education, we're really just looking to help them avoid progressing the disease. So alcohol abstinence is pretty critical to help slow that progression, since that was one of our main causes. We also want to make sure that patients are taking their medications correctly, following dosing exactly, and understanding the purpose and or side effects to avoid those harmful interactions. As well as we want to make sure that their diet and nutrition are following a low sodium diet just to reduce that fluid retention. And at the same time, we also want to monitor protein intake just to prevent any ammonia buildup. So with that being said, we want to make sure that we're instructing them to take those vitamins as Clay had just described, if they're prescribed, of course. And then also, again, just avoiding those hepatotoxic substances such as acetaminophen or Tylenol, aspirin, and even some herbal supplements. But we also want to teach them to report serious symptoms that can include vomiting blood, black stools, confusion, LOC changes, and all that stuff needs to be reported to the HCP immediately.
Okay, and then lastly, we have our pathophysiology flow diagram, which shows liver disease as it progresses. So starting at the top left, begins with liver inflammation. This inflammation causes early symptoms that include pain, fever, nausea, vomiting, anorexia, and fatigue. This later progresses to liver inflammation that leads to liver necrosis, which means liver cells dying. When this happens, the liver loses its ability to properly metabolize bilirubin. This leads to hyperbilirubinemia and jaundice. Patients may also develop light-colored stools because less bile reaches the intestines, and dark urine due to increased urobilinogen. Additionally, decreased bile flow causes reduced vitamin K absorption, which leads to bleeding tendencies. This is important clinically because patients with liver disease are at high risk for bleeding complications. Liver necrosis also causes decreased metabolism of proteins, carbs, and fats. This leads to hyperglycemia, decreased plasma proteins, and ascites and edema due to reduced albumin production and fluid shifts in the tissues. Another major effect is decreased hormone metabolism. This results in increased androgens and estrogens, causing gynecomastia, loss of body hair, menstrual dysfunction, spider angiomas, and palmar erythema. You can also see increased ADH and aldosterone, which further contributes to fluid retention and edema. And then as liver damage worsens, biochemical alterations occur. These include elevated AST and ALT, elevated bilirubin, low serum albumin, prolonged PT, and elevated alkaline phosphatase. These labs values help confirm liver dysfunction, as we mentioned earlier. And then progression of liver damage leads to liver fibrosis and scarring, which eventually causes portal hypertension. Portal hypertension results in ascites, edema, and splenomegalia, then contributes to anemia, thrombocytopenia, and leukopenia. Portal hypertension also causes varices, including esophageal varices, hemorrhoids, and caput medusae, which are those superficial abdomen veins. And these are dangerous because they can rupture and cause life-threatening bleeding. And then as liver function continues to decline, the liver failure develops. This can lead to hepatorenal failure, where kidney function begins to fail due to severe liver dysfunction. Liver failure also leads to hepatic encephalopathy, which occurs when toxins like ammonia build up in the bloodstream and affect brain function. This can progress to hepatic coma and ultimately death if not treated. So that is kind of the patho diagram for how that progresses. And then lastly, we have our references down here. That's all.